Hello friends, so let us now discuss the first part of the pharynx, that is the nasopharynx, also known as epipharynx. So remember, as I told you, that nasopharynx is the uppermost part of the pharynx, so it is also known as epipharynx. So this nasopharynx, we know it lies behind the nasal cavity, okay, from the skull base to the hard palate. So let's look at this photograph of nasopharynx. Okay, so we can see over here the skull base. This is the sphenoid sinus. So the sphenoid bone forms the skull base, and this over here, this is the hard palate. So in between we have the nasopharynx. Now what all structures we can see in this nasopharynx? Number one, you can see the opening of eustachian tube. So eustachian tube we also discuss in the ear in detail. So this tube is also known as pharyngotympanic tube or the auditory tube. So this tube, eustachian tube, we know it connects the middle ear to nasopharynx. Okay, so it connects the middle ear, rather I should say anterior wall of middle ear to nasopharynx. Which wall? Lateral wall. Okay, so lateral wall of nasopharynx. So we have one opening of eustachian tube on each side in the nasopharynx. Now this tube we know is made up of both bone and cartilage. The lateral 1/3 is bony, the medial 2/3 is cartilaginous. So this is which end? This is the cartilaginous end of eustachian tube. Okay, so this end which we can see in the nasopharynx is the cartilaginous end, and this end slightly protrudes into the nasopharynx. So because it is protruding, it forms a bulge in the nasopharynx, okay, and that is known as torus tubarius. So what is torus tubarius? Torus tubarius is the bulge of the cartilaginous end of eustachian tube in the lateral wall of nasopharynx, right? So this bulge over here, this is known as torus tubarius. Okay, now another important structure that you can see in the nasopharynx is the lymphoid tissue in the posterior superior wall of nasopharynx, which we call as adenoids. Okay, so you can see over here I have marked the adenoids. So this is the lymphoid tissue in the posterior superior wall of the nasopharynx. Right, now what do you see in these adenoids? In these adenoids, in the midline, you can see a recess. This recess in the nasopharynx, in the adenoids, this is known as nasopharyngeal bursa. Okay, so this is known as nasopharyngeal bursa, and this is the place where the notochord is attached in the embryonic life, intrauterine life. Right, so this is the place where the notochord is attached. Okay, now remember, there is a disease that is known as chordoma. Okay, this disease known as chordoma. Now, the chordoma arises from the remnants of notochord. All right, so if somebody asks you what is the most common location for origin of pharyngeal chordoma, so you see, we now know where the notochord is actually attached. So that is the nasopharyngeal bursa. So nasopharyngeal bursa, this is the most common location for origin of pharyngeal chordoma. Right? Okay. Now, see, sometimes what happens, there is inflammation. There can be an infection. There can be allergy. So whatever the reason, there is an inflammation, and because of this inflammation, this nasopharyngeal bursa may get blocked. So if it gets blocked, what happens? The secretions inside the bursa, they start getting collected. So because of this collection of secretions, there may be a formation of a cyst-like mass over here. Okay, so there may form a cyst-like mass over here, and this may block the nasopharynx. So remember, nasopharynx is the midline structure. It lies behind the nasal cavity, both the nasal cavities. So if there is a mass in the nasopharynx, it can block both the nasal cavities. And such a patient will present to us with complaint of bilateral nasal obstruction. Okay, so nasopharyngeal masses, they present with bilateral nasal obstruction, right? Okay, so this patient will present with bilateral nasal obstruction. And what is there? There is a cystic mass in the nasopharynx which has originated from nasopharyngeal bursa. Okay, so we call this disease as Thornwald's disease, right? So this cystic mass is known as Thornwald's disease. It's a cystic mass. If it gets infected, you can even call it as Thornwald's abscess, right? How will the patient present? Patient presents with nasal obstruction, bilateral. When you examine, you will find a cystic mass which is originating from the place of nasopharyngeal bursa. How will you treat this patient? For treating, you can simply do incision and drainage. Okay, so the treatment for Thornwald disease is incision and drainage. So you give an incision and you drain the collection inside it, whether it is a mucus secretion collection or it is pus, you can drain it. Now remember, because we don't want that this bursa should once again close down and again form a Thornwald disease, so we give a cruciate incision. Okay, so what do we give? We give a cruciate incision. So it's like this. This is a cruciate incision. So it will have least chances of closure. But if there is still a recurrence, you can even go and remove the adenoids. You can do a adenoidectomy. Anyways, so remember now my MCQ over here. The MCQ over here, pharyngeal chordoma arises from. The answer is nasopharyngeal bursa. But if I ask this question in the reverse language, nasopharyngeal bursa gives rise to. So if I say nasopharyngeal bursa gives rise to, now the best answer over here will be Thornwald's disease. I will give preference to this, then I am giving preference to pharyngeal chordoma. Okay, so this question has been asked both ways. Pharyngeal chordoma arises from, answer is nasopharyngeal bursa. But if I say in reverse, nasopharyngeal bursa gives rise to, then your answer has to be Thornwald's disease, right? Okay, now let's look above this nasopharyngeal bursa. So we look above this nasopharyngeal bursa, we see a small pouch, and that is known as Rathke's pouch. Okay, so you can all see the Rathke's pouch. It's a small pouch. Now what is the significance of this Rathke's pouch? You see, this Rathke's pouch is significant in the embryonic life because from here we know that the pharyngeal mucosa, it invaginate, goes up and forms the anterior lobe of pituitary gland. Okay, so pharyngeal mucosa goes from the Rathke's pouch up into the cranial cavity. So something from the pharynx is going to the cranial cavity. We can have formation of a tumor over here that is known as craniopharyngioma. Right? So remember, the craniopharyngioma, most common site of origin is Rathke's pouch. So easy to remember, pharyngeal mucosa goes to cranial cavity. So craniopharyngioma rises from Rathke's pouch. Okay, so these are all very important MCQs which have been asked in different exams. Okay, now what else do we have? So that is the first lymphoid tissue that I have taught you is the adenoids. We can also see that there are small lymphoid tissues all around this eustachian tube. So they are known as tubal tonsils, right? Tubal tonsils of Gerlach. That's the name for these small lymphoid tissues all around the eustachian tube. All right. Okay. Now another important structure, or I should say important place, is the space posterior superior to the eustachian tube opening. So this space that I have marked in green color, that is known as fossa of Rosenmuller. Okay, so that is a blind space. This fossa of Rosenmuller is a blind space. Now why it is a blind space? It is a blind space because the eustachian tube, as I told you, it has a torus tubarius. The cartilaginous part is protruding slightly into the nasopharynx. So what happens is the space behind it, posterior superior to it, it gets hidden. That is known as fossa of Rosenmuller. Now, what is the significance of fossa of Rosenmuller? So, let's remember significance, very important question. This is the most common site for origin of nasopharyngeal carcinoma. So, nasopharyngeal carcinoma we will be studying in detail later on, but just remember that we call it as NPC, short form nasopharyngeal carcinoma. NPC, the most common location for nasopharyngeal carcinoma is fossa of Rosenmuller. Right? Okay. Next, let's look at the adenoids. Now, before we go forward, let's look at these adenoids. So, adenoids are a lymphoid structure in the nasopharynx. Now, they are not always present. At the time of birth, these are very, very small. Okay, the adenoids are very, very small. These adenoids, they start growing at the age of 3 years. So, 3 to 5 years, they increase in size. Right? Okay. Now, 5 to 7 years, they are of maximum size. All right. 5 to 7 years, they are maximum size, and after 7 years, then they start decreasing. Okay, so after 7 years, they start decreasing in size. Now, that's a natural physiological growth pattern of adenoids. So, 3 to 5 years, they increase. 5 to 7 years, they remain maximum size. After 7 years, they start decreasing. And by 9 years to puberty, they will almost disappear. So, that means in adults, we will not have adenoids. Or there may be a very, very small rudimentary adenoids. So, normally, we do not find adenoids in adults. Right? Okay. Now, sometimes what may happen? You see, when there is a physiological growth, these adenoids, they do not cause any problem to the patient. But sometimes these adenoids, they grow much more than the physiological growth. Okay, so they grow and they can block the whole nasopharynx. Okay, so as I have shown over here, they have blocked the whole nasopharynx. Now, this is because of long-standing or chronic inflammation, and we call this condition as chronic adenoid hypertrophy or chronic adenoiditis. All right, so we will be studying about chronic adenoid hypertrophy or chronic adenoiditis in some time. So, just wanted to tell you that these adenoids may grow and may completely block the whole nasopharynx. Right, so that condition is known as chronic adenoid hypertrophy or chronic adenoiditis. Okay, so now after we have seen that illustration, let's look at this photograph. So, what is this photograph? This is the photograph of the nasopharynx. So, this photograph has been taken with the help of a 0-degree endoscope. So, 0-degree endoscope means, suppose this is the endoscope, our vision is like this, straight vision. Okay, so we can see all this in this vision over here. Right, if I take an angle scope, the angle scope will be like this. Okay, my vision will be here in this part. All right, so that can be a 30-degree endoscope, or it can even be a 90-degree endoscope. So my vision will be here in this part. Right. Okay, so there can be different angles of an endoscope. Now, this photograph has been taken with the help of a 0-degree endoscope, or you can say a straight endoscope. Now, where are we? We are in the right nasal cavity. We have put our endoscope to the right nasal cavity. We are at the posterior end of the right nasal cavity. Okay, what can we see over here? Now, in this photograph, number one most important thing that you can see over here is this opening over here. So, now what is this opening? This opening is the opening of eustachian tube. Okay, so right eustachian tube opening we can see over here. So, that's the number one opening. Now, remember, this is the cartilaginous end of eustachian tube. Okay, so the cartilaginous end protrudes into the nasopharynx, as I told you. So what is this? This is the protrusion which is known as torus tubarius. Right, students? So this is known as torus tubarius, and this hole over here is the nasopharynx. You can see that this is the nasal septum, the posterior end of nasal septum over here, and we can see the nasopharynx. Okay, some part of adenoids is visible over here, very small part. Of course, this is adult patient, so very small rudimentary part we can see over here in the adenoids. Okay, and we can also see a part which is posterior superior to the eustachian tube opening. See this area. Okay, now there is some secretions over here in this area, and that is your fossa of Rosenmuller. Okay, so remember, that is very important part. It is asked in the exam. A photograph may be given to you, and you may be asked to identify the fossa of Rosenmuller, or the eustachian tube opening, or the torus tubarius, or even the adenoids. Okay, so that is your fossa of Rosenmuller. It's a blind space. You see, even with the help of endoscope, we are not able to see exactly inside because we are using a straight endoscope. We may be able to see only when we use an angled endoscope, that we can see into the fossa of Rosenmuller. All right, now let's come to this question. So as I was telling you, questions are very common over here. So this question was asked recently in the FMG August 2020 exam. Following is the endoscopic image of nasopharynx. Identify the encircled site. So you can see over here in this image, we can see that this is the nasopharynx image, and they have shown right side eustachian tube opening, left is slightly coming into the picture. They have marked with the arrow, and they have encircled this place over here. So what is this place? Posterior superior to the eustachian tube opening, that we know is the fossa of Rosenmuller. So the answer to this question was fossa of Rosenmuller. Right? Okay, let's go to the next question. The next question, again it was asked in the NEET January 2018 exam. Which of the following is true about torus tubarius? So what was torus tubarius? It's a bulge of the eustachian tube. Okay, the cartilaginous end of eustachian tube. So nasopharyngeal bursitis, no, that's not a correct answer. Nasopharyngeal bursitis, that will be known as Thornwald disease. Okay, so that is known as Thornwald's disease. We know that. Okay, most common site of carcinoma nasopharynx, so that we know is fossa of Rosenmuller. That is also not the answer. Tubal elevation in lateral wall of nasopharynx, that is the correct answer. Okay, gives rise to Rathke's pouch, that's a wrong answer. Rathke's pouch rather gives rise to craniopharyngioma. Okay, right. So answer to this question was that torus tubarius is a tubal elevation. It's a eustachian tube bulge in the lateral wall of nasopharynx. Okay, let's come to next question. This question was asked in the NEET January 2018 exam. Nasopharyngeal chordoma. Okay, so I have already told you this question. This arises from, answer is nasopharyngeal bursa. Okay, that's the midline recess where the notochord is attached in the embryonic life. Next question we can see over here. Most common tumor from Rathke's pouch. So we know from Rathke's pouch, most common tumor is craniopharyngioma. This also we discussed. Okay, next question. Let's come and look at this image. Now what is this image? Thornwald disease. You can see over here that there is a cystic mass which is arising in the nasopharynx from the posterior superior wall where we have the adenoids. So from there a cystic mass, that is from generally from the nasopharyngeal bursa, so that is the Thornwald disease. I have already told you it can cause bilateral nasal obstruction, and what we do in the treatment, we will do incision and drainage. Okay, the incision given is a cruciate incision to decrease the chances of recurrence, and if there is still a recurrence, you can even go and remove the whole adenoids. You can do adenoidectomy. All right, now nasopharyngeal bursa infection. This leads to, answer is Thornwald's disease. So we just saw that, and it was asked in DNB June 18 exam. So remember, in the NEET January 18 it was asked, pharyngeal chordoma arises from, so answer was nasopharyngeal bursa. Now nasopharyngeal bursa gives rise to, answer is Thornwald's disease. Okay, now let's come to the chronic adenoid hypertrophy or chronic adenoiditis. So we talked about the chronic adenoid hypertrophy or chronic adenoiditis earlier. So now what happens that these adenoids, they have a physiological pattern of growth, but sometimes they keep on growing. That's because of the chronic inflammation. Okay, and then they start blocking the nasopharynx, they start blocking the posterior choana. Look in the first image, what do you see over here? You see that adenoids are coming into the nasal cavity. They have completely blocked the posterior choana. Look in the second photograph and you will see that only a small opening is left. The remaining whole of choana is filled with the adenoid mass, and patient practically has no space to breathe. Okay, so that is your chronic adenoid hypertrophy, which we will study. Okay, now firstly let us see the growth pattern of these adenoids. Now adenoids, you can see, as I told you, that the 3 to 5 year age group, this is the age group when they are of maximum size. So there is a growth pattern, and this is the age group when they are growing. Okay, and after 7 years then they start decreasing in size. Okay, so you can see the 3 to 5 years, this is the maximum time and the rate of growth is very high, and then they start decreasing. Okay, tonsils we will be studying in oropharynx, but as you can see that the growth rate of these tonsils, you can see that they reach adult size little bit late, that is somewhere between 8 to 12 years they reach the adult size. So that is around the time of puberty. Okay, so the maximum size may be reaching around puberty, whereas the adenoids, they reach the maximum size around the age of 5 to 7 years. Okay, next, what is the problem that this patient with chronic adenoid hypertrophy will have? How will the patient present? So the patient generally presents to us with bilateral nasal obstruction. Okay, so if there is bilateral nasal obstruction, what will be the problem? The patient will have mouth breathing. This child, he will have mouth breathing. His mouth will always be open, right? Okay, what else will the patient have? The patient can also have nasal discharge. Why nasal discharge? Because the nasal discharge is not able to go into the pharynx. You see, the posterior choana is completely blocked. So all the nasal discharge will come out from the anterior nares. And because of this standing discharge, patient can even have infection. Okay, he can have infection in the nose. So patient can have chronic rhinosinusitis. So generally a child presents to us with these complaints. All right, so the child is generally of the age of 5 to 7 years. So remember, 5 to 7 years, the adenoids are of maximum size. So generally a child with age group 5 to 7 years presents with nasal obstruction, which is generally bilateral, and there is nasal discharge, and he comes to us, we will find adenoid hypertrophy, chronic adenoid hypertrophy. But what will we find on examination? You see, this child is having mouth breathing. Okay, he is breathing through mouth constantly. So what will happen? His mouth is always open. Okay, now what happens because of this? Because of this, some changes start taking place in the skull, in the bone. What changes? You see, to adjust the breathing through the mouth, now what happens is that the palate, the hard palate, it becomes high arched. So as you can see over here, especially in the second photograph, you can see over here that this palate, it is quite high arched palate. Why? Because there is no airflow to the nasal cavity. The whole airflow is through the oral cavity. So the palate becomes a high arched palate. Right? Now the palate is not growing laterally. You see, it has become high arch, so it is not growing laterally. So because it is not growing laterally, now what happens? These anterior teeth, you can see over here, these anterior teeth, they don't have any place to grow. So they start overlapping each other. So this is known as overcrowding of anterior teeth. Right? So when we'll examine, we'll find that this child has high arch palate, there is overcrowding of anterior teeth. Okay, what else? What else we can see? We know that this child's mouth is always open. So you can see that the child mouth is always open, is breathing through the mouth. Now the nose, it appears like this nose is pinched because he is not using the nose. So there is no airflow through the nasal cavity. Patient will have pinched nose. Okay, and the face of the child becomes an elongated face. So together this is known as adenoid facies. All right. So what all is there in adenoid facies? We'll have a elongated face, the mouth is open, the nose appears pinched nose, and then there is high arch palate and overcrowding of anterior teeth. Okay. All of them together is known as adenoid facies. So that means the adenoid is now affecting the facial bony structure of the child. Okay. Now what we will do in these circumstances? We have to remove the adenoids. If there is a chronic adenoid hypertrophy, you may try with some antibiotics and anti-allergics. But if the patient does not improve, then we have to do adenoidectomy. Now, how can you confirm a case of chronic adenoid hypertrophy? To confirm a case of chronic adenoid hypertrophy, what we can do is we can do an X-ray soft tissue neck lateral view. Okay, so STN over here stands for soft tissues of neck, soft tissue neck lateral view. Okay, so now before I take you to the X-ray, let's look at this image. So this image we discussed in the starting of the pharynx. We know this is the nasal cavity, and then we have the pharynx, which we can divide into three parts: the nasopharynx, the oropharynx, the hypopharynx or the laryngopharynx. Okay, now this part over here, this is the larynx, and below that we have the trachea. So this over here is the trachea, right? Okay, so that much we know. We can also see in this part over here, this is the soft palate and the uvula. We can also see over here that this is the epiglottis. We can see that this over here, this is the hyoid bone. Okay, now we can see over here in this that this over here, this is the hyoid bone. All right, so these structures are quite visible to us. Now let's look at the X-ray. So this is a soft tissue neck lateral view X-ray, and what do we see over here? To understand this X-ray, we will trace the airway. How do we trace the airway? We start over here right from the anterior nasal vestibule, and we start over here. We can see over here that this is the nasal cavity, and if we trace the nasal cavity, we enter to the nasopharynx. Okay, and you can from here go into the oropharynx. What do you see over here? You can see a structure over here which is hanging, that is your soft palate and uvula. Right? Now if you go into the oropharynx, you can identify over here a structure. Which structure? You can see the hyoid bone. So quite nicely visible hyoid bone, and this structure over here that you can see over here, that is the epiglottis. So you enter through the epiglottis and you can go into the larynx. So this portion over here is the larynx. Below the larynx we have the trachea. Right? This is a normal X-ray, okay, where we can trace the whole airway from the nasal cavity to pharynx to larynx and trachea. Okay, this is a very, very important X-ray. Why? Because in one X-ray we are able to see the complete upper respiratory pathway. So in fact, even despite development of CT scan and MRI these days, this X-ray view is very important, because in one X-ray view, in a quick shot, we are able to see the entire upper respiratory pathway. Okay, so it is used, it is one of the x-rays which is still commonly used in ENT, and it is asked in the exam therefore multiple times. All right, now let's compare this normal x-ray that we have just studied with this another x-ray. What do you see in this x-ray? Now the first thing that you should notice over here in this x-ray, in the second x-ray, that this x-ray you can see over here that these teeth, they are unerupted teeth. Look over here. Whereas over here you can see that all these teeth are erupted. You can even see the roots of the premolars and the molars, whereas you can see over here the unerupted teeth. So that means this was the x-ray of an adult, whereas this is the x-ray of a child. So that's the first impression you get if you look carefully at the unerupted teeth. All right, now we start tracing the airway, we go into the nasal cavity, and as soon as we reach into the nasopharynx, we find that there is no airway. It is blocked by a mass which is arising from the posterior superior wall of the nasopharynx. Okay, and that is what mass in a child? It is most likely a case of adenoid hypertrophy. Right? So this over here, this is a case of adenoid hypertrophy which is completely blocking the posterior choana on both the sides, completely blocking the nasopharynx. Right? Okay. Now before I go ahead, let us discuss one more x-ray. Now look at the first x-ray. Once again, as soon as you look, you can see the unerupted teeth over here. So unerupted dentin, that clearly means that this is an x-ray of a child, right? So we have a child x-ray, and if we trace the airway in the nasal cavity, when you reach the nasopharynx, again you can see a mass which is arising from the posterior superior wall of nasopharynx, right? So you can see a very, very thin airway is present, very, very thin airway is present, which is anterior inferior to the mass. So what is this mass? This mass is your adenoid. Okay, so this mass over here is your adenoid. This is a case of adenoid hypertrophy, and we see that we see that the airway is anterior inferior to adenoids. That is very important, that if small airway is left, it is left anterior and inferior to the adenoid mass. Now let's look at the second x-ray. Now when we look at the second x-ray, so look carefully, we see another mass. Now if I am, you see, highlighting this mass is coming from the nasal cavity, and you can see that this mass is hanging in the nasopharynx going up to oropharynx. Okay, so you can see this mass hanging in the nasopharynx and oropharynx. Now if we look carefully, we will see that there is a airway in this patient also. Okay, so if you look this airway, this patient has a crescent of air over here. Okay, so I am highlighting that crescent of air. So it has this crescent of air over here, which is posterior superior to mass. Okay, so you see now the air is posterior superior to this mass. So what is this mass? This mass is hanging, coming from the nasal cavity, hanging in the nasopharynx and oropharynx. This is your AC polyp, enterochoanal polyp, which we talked in the nose topic. So that's enterochoanal polyp, grows behind towards posterior choana. So it may go into the nasopharynx, sometimes hang in the oropharynx, and this is having a air above the mass. Okay, this sign is known as crescent sign or dot sign. Okay, so remember, the crescent sign or the dot sign is seen in AC polyp. Just remember, it is seen in AC polyp, and this is how we differentiate AC polyp from adenoids. Okay, I have not taught you crescent sign or dot sign in the nose. Rather, I am teaching you here in the pharynx topic, because you have to be able to differentiate this from adenoid hypertrophy. Okay, so the idea is to teach you here, you can understand both the topics, the adenoid hypertrophy and the AC polyp. All right, remember, crescent sign or dot sign is seen in AC polyp, and this is how we differentiate on an X-ray AC polyp from adenoid hypertrophy. Okay, now remember, nowadays we don't do X-ray for AC polyp. What we do nowadays, we do CT scan, as I told you. So suppose I look at a CT scan. This is a CT scan. Okay, and when I look at this CT scan, what do I see? Now in this CT scan, you can clearly see that this side, right side maxillary sinus is all right. There is air inside it. But the left side maxillary sinus, you can see that this is filled with some secretions. Okay, so this is filled with some secretions. And when I look in the nasopharynx, you can see over here, this is the nasopharynx, I can see that there is a mass. Okay, but around the mass, you can see that all around the mass, there is some air present. You see, all around the mass, there is air present. So that is the dot sign in the CT scan of AC polyp. So you can say dot sign or crescent sign in the CT scan of AC polyp. Right? Okay. So dot sign is seen in AC polyp, and this is how we differentiate this from the adenoid hypertrophy. Okay. So what treatment will you do for adenoid hypertrophy? The treatment that we will do for adenoid hypertrophy is adenoidectomy. So that means we will surgically remove the adenoids. All right, what are the indications for adenoidectomy? So let us discuss the indications for adenoidectomy. Now, number one indication is nasal obstruction. Okay, so what kind of nasal obstruction will this child have? Now, this child generally has bilateral nasal obstruction. Okay, so child, we know the child has bilateral nasal obstruction. So because of this bilateral nasal obstruction, what will happen to child? Child will have mouth breathing. So we discussed, because of mouth breathing, he'll have other complaints like adenoid facies. Okay, the child may have rhinolalia clausa. So what is rhinolalia clausa? See, rhinolalia clausa, it simply means absence of nasal resonance in voice. You see, when we speak, our voice, it also resonates in the nasal cavity and then it comes out. Okay, that nasal resonance is important to give a particular quality to our voice, and especially to speak and differentiate some words such as M and N. Okay, now in case of rhinolalia clausa, because of the mass, the nasal resonance is gone. The air is not able to go into the nasal cavity, so the nasal resonance is gone. Right? Now, an opposite to this may be a condition which is known as rhinolalia aperta. Okay, so rhinolalia aperta means excess of nasal resonance. And where can we find this rhinolalia aperta? So that is found in case of cleft palate. So in case of cleft palate, too much of the air will go while we speak into the nasal cavity, so the nasal resonance will increase. Right? Okay, so if the child comes with nasal obstruction and is having rhinolalia clausa, and if the child has OSA, OSA stands for obstructive sleep apnea. So obstructive sleep apnea is again an absolute indication for adenoidectomy. So we will be discussing OSA in some time. All right, so I'll pick up the topic there. Let's go to the second indication for adenoidectomy. and that is adenoid facies. So what is there in adenoid facies? We discussed number 1, elongated face, number 2, open mouth, number 3, pinched nose, number 4, high arched palate, and number 5, overcrowding of anterior teeth. Right? Okay. Next, bilateral serous otitis media. So serous otitis media also we have discussed in the ear. We know this is because of dysfunction of the eustachian tube. Okay, and in case of adenoids, adenoids arises in the center. It is from the posterior superior wall. This is a midline structure. So when it grows, it will block both the sides eustachian tube. All right. So it blocks both sides eustachian tube. So bilateral eustachian tube blockage, and patient has bilateral serous otitis media. That means the patient will have bilateral conductive hearing loss. Okay. Next, patient has recurrent acute otitis media. So the eustachian tube blockage is there. And then there is infection in the adenoids. Adenoids are chronically inflamed. They may be chronically infected. So they are a source, they are a nidus of infection, and infection can repeatedly go into the ear, and patient can have recurrent attacks of acute otitis media. Okay, then again you have to do the adenoidectomy to remove this source of infection, which is again and again coming into the middle ear. Right? The next indication is CSOM associated with chronic adenoiditis. So now there is a chronic otitis media in the ear, and the cause is chronic adenoid hypertrophy. So unless you treat the chronic adenoid hypertrophy, you cannot treat the chronic otitis media, because that will recur. The eustachian tube function is gone, and because of that there is chronic infection in the middle ear, and it is affecting the tympanic membrane, and there is a chronic otitis media, right? So you treat the adenoids first so that you are able to treat the chronic suppurative otitis media. Okay, and next we have the recurrent rhinosinusitis. So you see the adenoids hypertrophy, they are blocking the nasopharynx, they are blocking the posterior choana. So nasal secretions, they accumulate inside the nasal cavity. Patient is having recurrent rhinosinusitis. All right. So when the patient presents to you with these problems, you have to do adenoidectomy. These are absolute indications for adenoidectomy. Okay, that means you have to do adenoidectomy in these cases, right? So let us now come to the obstructive sleep apnea. Okay, so obstructive sleep apnea is also known as OSA. And I was talking in the adenoids that if there is a nasal obstruction by the adenoids, they can even cause OSA. So what is this OSA? Let's understand. You see, sleep apnea. So what is the meaning of this apnea and why it is happening in the sleep, and especially the obstructive type? So let's understand this OSA. Let's first look at this video. So now what happens when the patient sleeps? Many a times the palate, especially the soft palate, the pharyngeal muscles around it, as well as the tongue, you see these structures, they fall, they close down, and because of the fat, obesity, different reasons, they narrow the airway. So when they narrow the airway, they may cause a sound known as snoring. But if there is a complete obstruction like over here, they may cause a complete obstruction. Okay. Now, what happens because of this? Okay. Let's first understand apnea. Apnea in simple word means cessation, complete stoppage of breathing. You see, we human beings, when we are born, we are all obligate nasal breathers. We can't breathe through mouth. Okay, we are obligate nasal breathers. Mouth breathing we learn by practice. By 1 month, that is 28 days, 4 weeks time, we start to do mouth breathing. So mouth breathing comes by exercise. Now when we sleep, in the deep sleep, in the deep sleep phase, all the learned reflexes, they go away. And now we again turn back into nasal breather. Now if there is any mass any lesion, or maybe the tongue base is bulky, or the patient is having obesity and the pharyngeal wall has been pushed inside. Now, because of this, there may be a narrowing of the airway, as I just showed you in the video. And because of that, the airway may close down. So there is an obstruction. And because of this obstruction, patient is not able to breathe through nose. And we know he is in deep phase, he cannot breathe through mouth. Right? So he'll go into a phase of apnea. Now what happens because of this apnea? Because of this apnea, the patient will wake up. Why the patient will wake up? Because the carbon dioxide will build up in the blood. This carbon dioxide will stimulate the chemoreceptors in the brain, and that will wake up the brain. So the brain will wake up and the learned reflexes will partially come back. The patient will open the mouth, gasp the air in, he'll produce a sound, and that sound we all know, we call it as snoring. Right? And the patient will wash out the carbon dioxide, and again the patient will try to go into deep sleep phase. As soon as the patient enters into deep sleep phase, again he will go into apnea. So this cycle of apnea and waking up will continue, and because of this, when the patient gets up in the morning next day, despite having 7, 8, 10 hours of sleep, he'll not be relaxed because he's not able to complete that deep phase of the sleep which is required. So that cycle is approximately 1.5 to 4 hours where the patient goes through all the phases of sleep but is not able to complete that because of this apnea. As a result, he will have a lot of problems. Okay, now we'll discuss those problems. So let us first discuss the scientific definition of apnea. So what do we call apnea? So in layman term, complete cessation of breathing. But for how long? So absence of breathing for at least 10 seconds. So that, my friends, is your MCQ over here. 10 seconds. No breathing for 10 seconds. Okay, so that we will call as apnea. Or we can also say that there is more than 90% drop in flow for 10 seconds. Okay, so how do we define the patient is not breathing for 10 seconds? Okay, we can say that the airflow has dropped more than 90%. Okay, and there is 3% or more oxygen desaturation. So you can put a pulse oximetry probe and we'll see more than 3% or equal to 3% decrease in the oxygen saturation. Right? Or we can say the patient is having an arousal. Patient gets up. So that also again shows us that patient is having apnea. Right? So any of these way we can define apnea. Now there is a similar term which is used that is known as hypopnea. So nowadays we even consider that hypopnea is as important as apnea because the patient oxygen level is going down, he is desaturating. So hypopnea is also important. Now how do we define hypopnea? So hypopnea is defined as more than equal to 30% drop in the flow for 10 seconds or longer. So remember, apnea was more than equal to 90% drop, hypopnea is 30% drop. Okay, or we can say that there is more than 3% oxygen desaturation. Right? And what else? Patient may be there. Patient may not have an arousal, patient may not get up, but if you measure it with the help of an EEG or if you do a nasal flow limitation pattern, so you can see that the patient is getting up. So he may not completely wake up, okay, but yes, with the help of this EEG, you can find out that there is a arousal, there is a waking up of the patient. Right? So this is how we define apnea and hypopnea. Now, the severity of OSA is defined by the apnea-hypopnea index. So as I said that we are giving equal importance nowadays to hypopnea as you were giving to apnea earlier. So now index considers both apnea and hypopnea. Okay, and it says that we have to measure the hourly rate of apneas plus hypopneas, right? If the rate is less than 5, it is considered normal. So AHI index less than 5 is normal, 5 to 15 is mild, 16 to 30 is moderate, and more than 30 is severe OSAH. So nowadays we just don't call it as OSA, we rather prefer to call it as OSAH, because hypopneas are also considered as equally bad as apneas, right? Okay, now let's come to obstructive sleep apnea hypopnea syndrome. So as I told you that the main cause is obstruction. Now, what do you mean it? There are more than 5 obstructive breath per hour. Okay, that only we'll call it as obstructive sleep apnea hypopnea syndrome. So remember, less than 5 APIs was considered as normal. Then patient has excessive daytime sleepiness. So this is important. That means despite sleeping for 7-8 hours or more, he's having daytime sleepiness, excessive daytime sleepiness, right? Okay, or patient may have 2 or more of the following, that is, patient has choking or gasping in sleep, patient has recurrent awakenings, patient has unrefreshed sleep, daytime fatigue, or patient has impaired concentration. So 2 or more of these should be present, then only we'll consider as a OSAH syndrome. Okay, right. Now, what can be the complications of this OSA? This question is asked in the exam a lot of times. What can be the probable complications? So number 1, let's see over here. Now you see these are the alveoli in the lungs. What happens? The blood is flowing through, and we know there is an exchange of gases. Carbon dioxide goes out, the oxygen is taken in. So you can see the blue is the venous vein and the red is the arterial vein. Now let's say because of this OSA, because of this obstruction, the complete airflow is not there. So some alveoli, they are receiving the air, the other alveoli, the air is not receiving. So what happens? Now you see in the well ventilated alveoli, the air passage is normal. But if there is a collapsed alveoli, the alveoli is collapsed because there is no air. Now what happens? The body will not send the blood to that alveoli. Okay, why? Because it wants to take as much oxygen as possible, so it will send all the blood to those alveoli where there is oxygen. Alright, so what happens? Suppose I close half the roads in the city, what will happen? The remaining half of the roads will have lot of traffic jam. So same way, half of the alveoli, let's say, are closed in the lungs, so what will happen? The remaining, all the blood is directed to the remaining half of the alveoli, and that leads to pulmonary arterial hypertension. Okay, so this patient slowly and slowly it develops pulmonary arterial hypertension. Now what will happen because of this? You see, the blood is pumped to the lungs by the right ventricle. So what will happen? The right ventricle will start undergoing hypertrophy. Okay, so we'll have a right ventricular hypertrophy. Okay, anything else? Yes. Now this ventricle, you can see over here, this ventricle will start undergoing dilatation, and the muscle of course undergoes hypertrophy. Sooner the patient will land up in right ventricular failure. We also call this cor pulmonale. Okay, this question has been asked in the exam. Remember, these patients of OSA can even develop cor pulmonale. Nowadays, the research is going on, and it is believed that because of this OSA, even the insulin release is affected. Okay, so conditions such as diabetes mellitus, conditions such as systemic hypertension, right, conditions such as stroke, they are all somehow related to OSA. So OSA is considered as underlying for a lot of different diseases, right? Let's come to this question. This was asked in the exam. Long-term complication in a child with upper respiratory blockage. So they are asking for long-term complication with upper respiratory blockage due to enlarged tonsils and adenoids. So you see, they have said there are tonsils and adenoids are enlarged, and there is an upper respiratory blockage. So that means they are talking about obstructive sleep apnea, and they are asking about long-term complication. And let's see what are the answers. Answers are about the lungs and the heart. You see, the atrial fibrillation, left ventricular hypertrophy, cor pulmonale, complete heart block. So they are talking about obstructive sleep apnea, but the complications are in the lungs or in the heart. So we know that OSA causes mainly pulmonary arterial hypertension, right ventricular hypertrophy. Okay, so this is wrong. Okay, and it causes cor pulmonale. So our answer to this question is cor pulmonale. Right? So that's the answer to our question. Now, what will we do for this OSA? How can we treat the OSA? Now, to treat the OSA, we can go for medical treatment, and the medical treatment basically relies upon CPAP, continuous positive airway pressure. Now, what is this CPAP? Now, CPAP is a machine that gives the air with a constant pressure. That pressure keeps the airway open. So you can see the patient sleeps, puts the mask on the nose, and it is connected to this machine that continuously pumps the air and maintains the pressure in the airway. Let's look at this video. Okay, so you see that this CPAP, it acts like a pneumatic splint. You see, now what happens, you put the mask and give the pressure, this pressure opens up the airway. And it will keep it like this. So the continuous pressure is maintained. That's how the name came, continuous pressure. So you see, it maintains this pressure, maintains the airway so that the patient is able to breathe, keeps the airway open. So very good solution. No surgery, nothing. But the problem is in compliance. Why? It's a cumbersome machine. Patient has to put it. Some patients, they feel claustrophobic because of this. They're not able to comply with this machine. All right. People who are able to comply, they find very good, refreshing morning, next day. So they may continue it for a long time. But people who feel claustrophobic are not able to comply, we have to offer alternative treatments. So what alternative treatments can we offer? We can offer mandibular advancement splint. Now what is done in this? This is a splint which the patient puts in the jaw, and what will it do? It will push the mandible forward. So if a patient is having, you see, the blockage, the restricted airway because of the tongue base is heavy, it is falling back and it is blocking the airway, then he can put this mandibular advancement splint and it will push the mandible up, mandible forward, and it will open the airway, patient can breathe. Right? So you can see that now it has gone up and patient is able to breathe over here. Right? So that is again a non-surgical treatment. Now we can also go for surgeries. The surgery for OSA depends upon the level of obstruction. So there are three basic levels where the patient may have obstruction. What are these three basic levels of obstruction? Number one is the nose, nasal cavity. Okay, that's the number one. Patient may have enlarged turbinates, patient may have a deviated septum. So that's the number one. Number two is the palate. The palate, the soft palate may fall back and it may be blocking the airway. And number three is the tongue base. So tongue base may be blocking the airway. So these are the three main levels where a patient may have obstruction. So we have to find out first which is the level of obstruction, and then accordingly we go for surgery. Okay, suppose the obstruction is in the nose. So what we can do is, let's say over here, you can see that the septum is deviated. So we can correct the septum. So you can see that terminates are enlarged. So we can cut and reduce the terminates. We can do a terminoplasty. So let's see over here, when we correct the septum and do the terminoplasty, we can give wide airway to the patient to breathe. Okay. Now, suppose the problem is in the palate, we can do a surgery known as uvulopalatopharyngoplasty. I call it as UP3. Okay. Now what is done in this? This soft palate and the uvula, this may be cut and removed. Okay. So this is how we do it. We stitch it so that we create a good anterior-posterior airway. So this is how we can take care of the problem that is caused by the palate. But most of the times, the problem is by the tongue base. Now, to solve this tongue-based problem, we can do different kind of surgeries. The one that is tried is genoglossal advancement surgery. So what we do in this, we cut open the mandible anteriorly, and we can cut this part of the bone as we are seeing over here where the genioglossus muscle is attached, and we rotate and screw it. Quick, easy procedure to do. Now what happens by this? It pulls the genioglossus forward. So let's see over here, we can see that the tongue base is falling backwards, and now suppose we do this surgery. We cut the mandible over here and we pull the genioglossus forward. So what happens when you have pulled it forward? You can create a big airway over here. So that's known as genioglossus advancement surgery. As you can see, it's a pretty easy surgery to do, okay, and it gives very good results. Right? Now, the recent advancement in this is a robotic tongue-based surgery. So we can go inside the pharynx, and with the help of numerous robotic arms, we can do the surgery of the tongue base. So what we have to do is, you can see this is the tongue base, and in this tongue base on both the sides, you can see over here we have the lingual artery. Okay, now in between these two lingual arteries, this part of the tongue base we can cut and remove. Nowadays we have good instruments such as coablation, so we can cut and remove this part of the tongue base. Okay, this much part of the tongue base can be removed surgically so as to provide a very good airway to the patient which was earlier blocked by the tongue base. So we can do different surgeries nowadays to treat the obstructive sleep apnea. Right? Okay, let's come to the next disease, that is juvenile nasopharyngeal angiofibroma, also known as JNA. Right? Now, this is the most common benign tumor of nasopharynx. JNA is the most common benign tumor, and the site of origin is lateral nasal wall. So posterior end of lateral nasal wall, that means near the sphenopalatine foramen and pterygoid base. Earlier it was said that it rises from the sphenopalatine foramen, but the latest edition of Scott Brown says that it is near the sphenopalatine foramen and pterygoid base. It means the same thing. We have the sphenopalatine foramen. Let's look in this photograph. We have the sphenopalatine foramen. Where is the sphenopalatine foramen in this photograph? Let's look by the arrow. That's the sphenopalatine foramen over here. Okay, so where is the pterygoid base? You see, this is the pterygoid process. So this is the pterygoid base. So earlier it was said that JNA arises from the posterior margin of sphenopalatine foramen. Now it says it lies between the sphenopalatine foramen and pterygoid base. So that means ultimately they are saying the same thing. Okay, they are still saying that it is rising from this place. Right? So ultimately they still mean the same thing. It is rising from the same place, whether say they say posterior margin or posterior superior margin of sphenopalatine foramen, or they say near sphenopalatine foramen and pterygoid base. So I have encircled this place. That is the most likely place for origin of JNA. Right? Okay. Now, what are the characteristics of this JNA? Now, as the name suggests, this JNA is found only in adolescent males, juvenile males, adolescent males. All right. So what age group? The age group is, you can say, 8 years to 22 years. Why 8? Some males, they acquire adolescence early, some they acquire late. So 8 years is the earliest possible to 22 years the latest possible. Right? So adolescent males. Now why only males? Why not females? Because this is a testosterone male androgen dependent tumor. Okay, so it is not seen in females, it is seen exclusively in males. All right. Now what else? There is no true capsule. Although this is a benign tumor, this tumor does not have a true capsule. Right? Okay, it has multiple blood supplies. In fact, wherever it grows, it will take the blood supply from that place. Okay, and remember, this tumor is juvenile nasopharyngeal angiofibroma. Now, whenever I say the word angio, I automatically mean blood vessel. Okay, so this tumor is made up of blood vessels. It is taking multiple blood supplies, right? Now, a blood vessel has 3 walls. There are 3 layers in the wall: tunica intima, tunica media, and tunica adventitia. Okay, now what is tunica media? The tunica media in the blood vessel consists of smooth muscles. What is the function of these smooth muscles? Number 1, in the arteries, they maintain the blood pressure. Okay. Number 2, whenever the vessel is injured, this tunica media, the muscles will contract, and when they contract, they stop the bleeding. Right? What happens in JNA? In JNA, there is no tunica media. Okay, so there is no tunica media. Okay, now the blood supply, as I said, in JNA is multiple blood supply. Right? But we have a theory for origin of JNA. Now the most accepted theory published now is the first branchial arch artery theory. Now what does this theory says? This theory says that the JNA arises from the first branchial arch artery. Which is the first branchial arch? The first branchial arch is the mandibular arch. And what is the artery for the first arch? The artery is the maxillary artery. Okay, or we also know it as internal maxillary artery, IMA. Right? Okay, now that means now the most accepted theory is JNA is rising from the maxillary artery. Okay, and maxillary artery, the branch which comes into the nasal cavity is the sphenopalatine artery. So remember, if somebody asks you what is the most common blood supply, you see, remember the JNA is rising from the sphenopalatine artery. That's a branch of maxillary artery. So that is of course the most common blood supply. That is the place from where it arises. Okay, it may grow and it can take the blood supply from a lot of different arteries, but most common will be sphenopalatine artery. If sphenopalatine artery is not given in your options, remember the answer that you have to mark is maxillary artery, because SPA is a branch of IMA, internal maxillary artery. Right? Okay. Now, how will this patient present? How will this patient of JNA present to you? As you have understood, this JNA has 3 things. Number 1, it has multiple blood supplies. Number 2, there is no true capsule. And number 3, there is no tunica media. Okay, very important, there is no tunica media. That means if the bleeding starts, it will not stop. Patient has profuse recurrent epistaxis. This is the most common presentation of JNA, profuse recurrent epistaxis. Now remember, that's a dictum in ENT. What is a dictum? If we have a teenage group, male patient presents with epistaxis, okay, a profuse recurrent epistaxis, our first diagnosis is JNA, unless and until proven otherwise. So if a patient, teen patient, male patient, epistaxis, profuse recurrent epistaxis comes to you, your first diagnosis has to be JNA until unless proven otherwise. Okay, so this patient will have profuse recurrent epistaxis. 3 reasons. Number 1, there is no true capsule. Number 2, there is multiple blood supplies. And number 3, there is no tunica media. Okay, right? Next, what else can be there? It's a tumor, it's a mass, so it can cause nasal obstruction. Okay, if the mass is on one side, it will cause unilateral nasal obstruction. If the mass goes into the nasopharynx, it can even later stages cause bilateral nasal obstruction. Right? Okay, there may even be cheek swelling. Okay, there may be a cheek swelling. Now my question is that the angiofibroma is in the nasopharynx. It arises in the posterior part of the lateral wall of nasal cavity. It grows in the nasopharynx. How can there be a cheek swelling? For that, it has to come out into the cheek. Okay, so how does it come out? So let's remember this diagram once again. This was over here the sphenopalatine foramen, right? So we just discussed this is the place where the JNA arises. Okay, let's look at this from the other side. This was looking from inside the nasal cavity. Let's look at it from the lateral side. Okay, so I have reversed, I have rotated the skull, and you can see over here a structure. I have marked it. That is your sphenopalatine foramen. You can see that sphenopalatine foramen. I am highlighting it once again. That is your sphenopalatine foramen. Okay, now understood? Everyone has got the idea. That is the sphenopalatine foramen. Now let's see what is this. We have the maxilla over here. Okay, and we have the sphenoid bone. This is the greater wing of sphenoid. This is the pterygoid process of sphenoid. Okay, we have the pterygoid process. Now between the pterygoid process and the maxilla, you can see over here we have a pterygomaxillary fissure. So that opening is known as pterygomaxillary fissure. So you can see deep inside there is a sphenopalatine foramen, outside there is a pterygomaxillary fissure, in between them there is a fossa. I have shaded that fossa, that's known as pterygopalatine fossa, also known as sphenopalatine fossa. If you remember from anatomy, we have a very important ganglion over here known as sphenopalatine or pterygopalatine ganglion in this place over here. Okay, must have studied this fossa in detail in anatomy. Now, if you come out of this pterygomaxillary fissure, okay, so if we come out of this pterygomaxillary fissure, you see over here I have shaded this area. Now this place is known as infratemporal fossa. So we have the zygomatic process over here. As you can see, I have cut this zygomatic process. Okay, so you see I have cut this zygomatic bone over here from the zygomatic process of temporal bone. Okay, so this zygomatic bone has been removed to show you this fissure and the fossa. Now medial to this zygomatic bone over here we have a infratemporal fossa, right? So you come out and you come in the cheek, that is the infratemporal fossa over here. Okay, so let's see once again. You can see the sphenopalatine foramen. You can see the green color pterygomaxillary fissure. In between them we have a fossa that's known as pterygopalatine fossa. Then you come out of pterygomaxillary fissure, you reach into the infratemporal fossa. Okay, so to form a cheek swelling, the JNA goes through a tunnel, and that tunnel is known as pterygomaxillary tunnel. Okay, that tunnel is known as pterygomaxillary tunnel. So remember, nasal cavity, from nasal cavity there is sphenopalatine foramen, and it goes lateral to sphenopalatine foramen. It will come in pterygopalatine fossa. It crosses from pterygopalatine fossa, it crosses the pterygomaxillary fissure. It reaches the infratemporal fossa, that is your cheek, and the JNA gives a cheek swelling. Right? This anatomy I have spent time because it is a very important anatomy. This tunnel is used at a lot of places and is very important to understand the JNA. Why? We will discuss it. Okay? Right? Let's see what we find on examination. Now, what will we see on examination? This is a benign tumor. It looks like a polyp. Okay. Now, this polyp, if you see over here, this JNA, I have marked it over here. How does it look like? It looks like a red, fleshy polypoidal mass. Okay. Remember the normal enteroconal polyp, the normal AC polyp is a pale glistening polyp. There is no blood supply, there is no enough supply on AC polyp. Okay, remember that. AC polyp, there is no blood supply, there is no enough supply. That is a pale glistening polyp. And how do you differentiate that with JNA? The JNA is reddish, fleshy, polyp-like structure. Okay, remember, if you touch the JNA, there will be a lot of bleeding. So you will not touch it. Remember, AC polyp, no blood supply, no bleeding on touch, no pain on touch, no bleeding on touch. JNA, if you touch it, there will be a lot of bleeding. Okay, so you don't touch the GNA, right? Got it? You will never touch the GNA if you suspect the GNA, because it will bleed on touch and then it will not stop. There is no tunica media. Okay, now what else can we see? We can see frog face deformity. So because of this tumor, the eyeball is pushed forward and laterally. Okay, the GNA goes in the orbit. So the GNA goes in the orbit, and because of that, the eyeball is pushed laterally and outwards. Okay, outward means patient has proptosis. Patient has proptosis. Plus laterally. So you see this intercanthal distance. If you notice, this intercanthal distance has increased. So increase in this intercanthal distance, that is known as telecanthus. So proptosis and telecanthus together, this is known as frog face deformity. Okay, so patient may also have frog face deformity. That means the GNA has gone into the orbital cavity. Okay, let's look at this question. Angiofibroma bleeds profusely because it has multiple blood supply, it lacks a capsule, vessels in it lack a contractile component. All of the following are true. Okay, so answer to our question is all of the above. Right? Now, how will you confirm a patient has having GNA? How will you confirm your diagnosis? What investigation will you do? Now remember, biopsy is absolutely contraindicated. Biopsy is absolutely contraindicated. It's a vascular mass that will bleed, does not have tunica media, all the reasons not to do the biopsy. And this question has been asked multiple times in the exam, which of the following investigations we will not do for GNA, and answer is biopsy. You will never do biopsy for GNA. Now if you suspect, what will you do? You will do a contrast enhanced CT scan. Okay, so you do a contrast enhanced CT scan. And what do we find in contrast enhanced CT scan? We find antral sign or Holman-Miller sign. Okay, let's look at this CT scan. What do we see over here? We see over here that there is a tumor. Now you see this tumor is a dumbbell shaped tumor. So look over here, this is a dumbbell shaped tumor. Okay, right? Some part is in the nasal cavity, some part this over here in between these two places, this over here, that is your sphenopalatine foramen and the pterygopalatine fossa. So between over here it has crossed this pterygopalatine fossa, and now it is lying over here in the infratemporal fossa. It is pushing the posterior wall of maxilla anteriorly. So what is antral sign or Holman-Miller sign? The posterior wall of maxilla. You see, this posterior wall of maxilla, it is pushed anteriorly. You can see over here, compare this with this side. That's the normal side. Okay, so the posterior wall of maxilla is pushed anteriorly. We also call it as anterior bowing. Anterior bowing of posterior wall of maxilla, that's known as antral sign and or Holman-Miller sign. Okay, now remember the pterygomaxillary tunnel. We discussed this tunnel. The angiofibroma goes from nasal cavity to the cheek, that is the infratemporal fossa, okay, through the pterygopalatine fossa. We discussed this tunnel. Now, what will happen to this tunnel? If the angiofibroma is going through this, it will widen the tunnel. Okay, so you see over here, this whole tunnel, it has become wide. This whole tunnel, it has become wide. Compare this to this side. You see over here, this side, this is the tunnel. You can see the tunnel is very thin on the normal side, but on the abnormal side, you can see the tunnel has widened. So widening of this pterygomaxillary tunnel, this is known as Hondusa sign, right? So this pterygomaxillary tunnel, the widening of this tunnel is known as Hondusa sign, and that is seen in GNA. Classical sign seen in GNA, right? Okay. How will you treat GNA? What is the treatment of GNA? Now, a lot of treatment methods have been described in the undergraduate textbooks as well as the postgraduate textbooks. Okay, now I'll tell you what. The 7th edition of Scott Brown had 4 pages of treatment of GNA. So they are described different procedures. The 8th edition has 1 page, less than 1 page, approximately only 1 column, because now the treatment of choice has become only one treatment, and that is your endoscopic excision. Okay, that's the treatment you have to remember. The treatment of choice nowadays is endoscopic excision of GNA. Yes, a lot of different methods have been described to remove the GNA, right? But now the treatment method that is sufficient from a small GNA to a very large GNA going into the intracranial cavity, endoscopic excision can treat almost all the cases. Okay, now before I end this topic, we also have to understand the staging of GNA. Okay, so I've kept that till the end, the staging of GNA. Before I go for staging, let's discuss this question. This was asked in the AIMS November 2018. Okay, so let's look at the question. This question was asked: a 16-year-old male patient. So you see, 16-year teenage group, number 2 male patient, complains of nasal obstruction and recurrent epistaxis. So as I said, male patient, teenage group, epistaxis. Recurrent epistaxis over here mentioned clearly. Okay, we have our first diagnosis as GNA until unless proven otherwise. Right? So we have our first diagnosis of GNA. Then there is nasal obstruction. So that means some mass is there. It again supports our diagnosis of GNA. Now, on CT scan of nose and paranasal sinuses, an enhancing mass is seen in nasopharynx. Okay, so when the question says that an enhancing mass is seen in the nasopharynx on CT scan, it confirms your diagnosis of GNA. So you have done the confirmatory investigation, your investigation of choice, confirmatory investigation is CT scan, you have done it, there is an enhancing mass in the nasopharynx, diagnosis is confirmed. Okay, with minimal extension into the sphenoid sinus and no lateral extension. So this is mentioned, minimal extension into sphenoid sinus, no lateral extension. What is the stage of this lesion? Alright, so let us do the staging of the GNA. Now to understand the staging of GNA, let me give you a basic idea. Suppose this is the GNA. Okay, this is the GNA. Now the GNA can spread in 3 ways. Number 1, it remains in the nose, in the nasopharynx, in the nose. That means it is in the center. So till the time it is in the center, it will be stage 1. The moment it starts lateral extension, okay, so till in the center, in the nose nasopharynx, it will be stage 1. The moment it starts its lateral extension, remember the tunnel, it will go into stage 2. And the moment it starts going up intracranial, it will become stage 3. Okay, that's the basic idea. Now let us look at the staging. The staging, there are multiple stagings. We are going to just remember 1 or 2. The most important that we are going to remember is the session staging. So we are doing the session staging for the GNA. Now the stage 1. Stage 1, GNA is limited to nasal cavity and nasopharynx. Nasal cavity and nasopharynx. So you see over here, this is the GNA. It is limited to nasal cavity and nasopharynx. That is your stage 1 GNA. Right? Okay. Now stage 1B. So that was stage 1A. Stage 1B. It goes into one or more paranasal sinuses. Okay, that is your stage 1B. Remember the question? The question said that the JNA is in nasopharynx with some extension into sphenoid sinus, no lateral extension. So what was the answer to the question I asked? The answer was stage 1B. Okay, look over here. This is the image. You can see that there is a JNA over here in the sphenoid sinus. This is exactly what was asked in the question. There is JNA in the sphenoid sinus. So this is stage 1B. Okay, so stage 1 was in the center, nose, nasopharynx, paranasal sinuses. Now it starts going into the tunnel. So it goes into the tunnel, lateral extension, it becomes stage 2. Okay, stage 2A. So when I say 2A, that means first part of tunnel. First part of tunnel was crossing the sphenopalatine foramen and going into pterygopalatine fossa. Okay, so stage 2A, it goes into pterygopalatine fossa. Look over here, we have this. It has gone into the pterygopalatine fossa, right? So that is stage 2A. Now stage 2B is it causes antral sign. Remember the antral sign? Anterior bowing of posterior wall of maxilla. Okay, so it causes the antral sign or it extends into the orbit. Remember, if it goes into the orbit, patient will have frog face deformity. So that will be visible from outside. Okay, so that is session stage 2B, lateral extension. Now, stage 2C is it goes into the infratemporal fossa. So look in this photograph, we have this JNA. Okay, so we have this JNA and it has gone into the infratemporal fossa, right? So it has appeared in the cheek. There's a cheek swelling, it appears in the cheek. Okay, so infratemporal fossa. Now, stage 3, it goes up, intracranial extension. As I told you, it goes up, it becomes stage 3, intracranial extension. So this is the session staging. It is a radiological staging for GNA. Now, a modification of this session staging is your Radowski staging. Okay, now the Radowski staging for stage 1 and 2 is same. Okay, so 1A, 1B is same. What was 1A? Nose and nasopharynx. What was 1B? Goes into one or more paranasal sinuses. Okay, stage 2 is also same. Stage 2A, it goes into the pterygopalatine fossa. Stage 2B, there is antral sign. Okay, now there is a slight change in stage 2C. So this much was same, Radowski staging, this much was same. Now stage 2C, there is a slight change. What is the change? The infratemporal fossa extension is without cheek or pterygoid plate involvement. So the pterygoid plate erosion is not there or the cheek involvement is not there. That means it is in the temporal fossa, but this swelling is still not visible. Okay. Now stage 3 has also been divided by Radowski. Stage 3A is minimal intracranial spread. Okay, stage 3A is minimal intracranial spread. So minimal intracranial spread means there is some erosion of the skull base, right? Pterygoid plate may be eroded, middle cranial fossa may be eroded, but there is minimal intracranial spread. What is stage 3B? Now Radowski has defined stage 3 into 3A and 3B, which sessions has not. So what is stage 3B? Stage 3B is extensive erosion or extension into the intracranium. Now that means there is a involvement of cavernous sinus. So with or without cavernous sinus involvement. Okay, so cavernous sinus, if somebody says involved, it straight away means it is stage 3B of Radowski, right? Okay, so these are the staging. Usually you have to remember the session staging. Sometimes you may be asked Radowski staging, especially the cavernous sinus involvement. So if that is there, remember it is stage 3B. Okay, that's the most important point from here. Treatment, I told you for GNA, the treatment is endoscopic excision. Okay, right? Next question we will solve. A 14-year-old male patient. So once again, 14-year teenage group, male patient, okay, presents with recurrent spontaneous bleeding. So once again, three things I have shown you: male, teenage group, recurrent spontaneous bleeding. My first diagnosis has to be JNA unless and until proven otherwise. Now, and on examination, a pink mass covered with mucosa is found in the nasopharynx. So they want to say that there is no capsule, but there is pink mucosa, false capsule, no true capsule. Okay, pink mass. So fleshy mass, pink mass points towards vascular mass. Which of the following is not to be done? Biopsy to confirm. Remember, I told you biopsy is absolutely contraindicated. This is something we never have to do. Okay, CCT we will of course do. That is our investigation of choice. Okay, if it shows JNA, we will go for endoscopic surgery. That is our treatment of choice. Sometime before doing surgery, we may also embolize the artery which is feeding this tumor. So we may pre-surgically embolize the artery so as to reduce the intraoperative bleeding, right? But one thing we will never do is biopsy. So our answer to this question is biopsy to confirm diagnosis. This we will never done. Question was, which of the following is not to be done, right? So that brings us to the next disease in the nasopharynx, that is the nasopharyngeal carcinoma, NPC. Okay, so we have already talked about NPC, nasopharyngeal carcinoma. We know nasopharyngeal carcinoma, the most common site of origin is fossa of Rosenmuller. Where is this fossa of Rosenmuller? It lies posterior superior to the eustachian tube opening. That's blind recess is known as fossa of Rosenmuller. Okay, most common type is squamous cell carcinoma. More than 85% cases, they have squamous cell carcinoma. Now, etiology. The nasopharyngeal carcinoma is generally seen in males. Okay, generally has a bimodal age distribution. So bimodal age distribution means 10 to 20 years it is common, then 60 to 70 years. So there are two age groups where it has a peak. Small peak in the 10 to 20 years, then we have another peak in the 60 to 70 years age group. Okay, Epstein-Barr virus. So this virus is associated with NPC, nasopharyngeal carcinoma. Okay, now it has been reclassified as human herpes virus, but Epstein-Barr virus is associated with NPC. There are other malignancies which are again associated with Epstein-Barr virus. So what are the other malignancies? So number one I have told you is NPC. Number two, we have Hodgkin's lymphoma. This question is asked in the exam. So Hodgkin's lymphoma. Now in the non-Hodgkin's lymphoma, we have your Burkitt's lymphoma. That is again associated with the EBV. Then we have in the non-Hodgkin's lymphoma only, we have immune deficiency associated non-Hodgkin's lymphoma, that is again caused by Epstein-Barr virus. And then we also have gastric adenocarcinoma. Gastric adenocarcinoma. So these all malignancies, they are thought to be associated with Epstein-Barr virus, including the NPC. Okay, now remember NPC is very common in the Chinese population. Okay, now Chinese population, there are different reasons why it is said that NPC is common. Number one is that they have a high prevalence of Epstein-Barr virus. Number two, the Chinese population is thought to be consuming a lot of salted fish. Especially the southern China, they consume a lot of salted fish, and this has been, there is a hypothesis that it causes the NPC. Okay, another hypothesis for the Chinese population is that they burn a lot of incense sticks. Agarbatti, the incense sticks, so they burn a lot of these incense sticks at their home, and the smoke from there is a hypothesis that this smoke may be causing nasopharyngeal carcinoma. All right, okay, but remember it is very common in Chinese population. Now, how does the NPC present? Remember, this is a malignancy. Okay, Now, a tumor can be a benign tumor, it can be a malignant tumor. If it is a benign tumor, it will grow and it will present with a mass effect. What do I mean by mass effect? It will present itself like a mass, or it will press something surrounding that and will present with that, or it may have some characteristic feature. So mass effect, or there may be some characteristic feature, like it may release some hormone, endocrine hormone, okay, or like in case of JNA, there is no tunica media, so it presents with bleeding, right? So mass effect is the nasal obstruction in JNA, the special effect is the bleeding, so it presents with bleeding. That's a benign tumor. Now what happens in a malignancy? Now malignancy has three effects. What are the three effects? The mass effect. Remember, more important than mass effect in a malignancy, there are two more things. Number one is invasion. So it will invade the surrounding tissue. Before it grows, it will start invading. So it will invade, it will destroy the surrounding tissue because of invasion. Okay? Or else it may undergo distant metastasis. So a malignancy can also undergo distant metastasis. So it may present somewhere else. Now what about NPC? Now the NPC, the clinical presentation, most common clinical presentation for NPC is cervical lymphadenopathy, cervical lymph node metastasis. More than 75% patients at the time of presentation have cervical lymph node metastasis. Okay, so more than 75% patients. Now, it's a general saying, whenever the malignancy metastasizes, the prognosis becomes bad. Right? We know that's a general rule in the body. Any malignancy undergoes metastasis to lymph nodes, to other places, the prognosis becomes bad. Okay, but remember, there are two malignancies in our body. There are two malignancies in which lymph node metastasis does not affect the prognosis. Okay, two malignancies in which the lymph node metastasis is early and yet the prognosis is good. Which are these two malignancies? Number one, of course, is NPC, nasopharyngeal carcinoma. Number two is thyroid carcinoma. So I'll repeat my statement again. Generally, we say that metastasis leads to poor prognosis. But there are two malignancies which have good prognosis despite early lymph node metastasis. So lymph node metastasis does not affect the prognosis, and that is in NPC and thyroid carcinoma. Both of them will have early lymph node metastasis, but prognosis is still good. Okay, right? Now, let's look at this photograph. We discussed it in the nasopharyngeal anatomy. Okay, now we know that we over here have the fossa of Rosenmuller. In this fossa of Rosenmuller, we have our NPC, nasopharyngeal carcinoma. So let's say this is the origin of nasopharyngeal carcinoma. Okay, now what can it cause? This nasopharyngeal carcinoma, it can grow and it can involve the eustachian tube. So suppose it grows and involves the eustachian tube that's nearby and it invades and it blocks it. What will happen? Patient will have serous otitis media. Okay, patient will have serous otitis media. What type? Unilateral. Why? Because the NPC is arising on one side. So it is unilateral serous otitis media. Okay, remember adenoids was in the midline. So adenoids cause bilateral, but NPC is causing unilateral serous otitis media. And this leads to unilateral conductive hearing loss. As we discussed in the earlier topic, so serous otitis media presents with unilateral conductive hearing loss. Right? Okay, what else can be there? You see, this NPC, it can go and it can involve the skull base. So if it goes up, it can involve the skull base. Okay, now if it involves the skull base, it can involve multiple cranial nerves. So it can cause multiple cranial nerve palsy. It can cause multiple cranial nerve palsy. So which all cranial nerves can NPC involve? So remember, NPC can involve all the cranial nerves. except one cranial nerve, one. Why one? Which is one? One is olfactory. Olfactory is quite here. You see, for involving one, NPC has to travel so much distance up. By the time NPC will go this much up, our patient will go up. Okay, right? So except cranial nerve 1, the NPC involves all the other cranial nerves. Right? Okay, so let's say it involves the 5th cranial nerve. So if it involves the 5th cranial nerve, patient will have same side, that is ipsilateral trigeminal neuralgia. Right? If it involves the 10th cranial nerve, patient will have ipsilateral palatal palsy. Right? Okay, so remember, conductive hearing loss, trigeminal neuralgia, palatal palsy, together they are known as Trotter's triad or sinus of Morgagni syndrome. Remember, the sinus of Morgagni is the space, anatomical gap between the upper border of superior constrictor and the skull base. From here, the NPC goes out and involves the skull base. So in that going out, it involves the eustachian tube, and then when it involves the skull base, it can cause multiple cranial nerve palsies. Okay, now how to remember the Trotter's triad? Very easy. We have N for neuralgia, we have P for palatal palsy, we have C for conductive hearing loss. So we say NPC. So remember, Trotter's triad is seen in NPC. The components are also NPC: neuralgia, palatal palsy, conductive hearing loss. Okay, somebody asks you which is the most common cranial nerve involved. Now the most common cranial nerve involved by NPC is the cranial nerve 6. This is the earliest, the first cranial nerve involved by NPC. And if the 6th nerve is involved, that means the NPC has crossed foramen lacerum. Okay, so that means it has crossed foramen lacerum. Right? Now, most common manifestation of nasopharyngeal carcinoma. Question asked in the FMG June 2018 exam: epistaxis, headache, nasal obstruction, cervical lymphnopathy. I told you more than 75% patients have lymph node metastasis at the time of presentation. Okay, despite that, prognosis is good. Right? Now, let us understand the spread of NPC, nasopharyngeal carcinoma spread. Now I told you most common spread is down, cervical lymphnopathy. Okay, that is the most common spread. What else it can do? It can go anteriorly. If it goes anteriorly, it can involve the eustachian tube. If it involves the eustachian tube, patient will have serous otitis media, unilateral serous otitis media. Remember, general involves one side eustachian tube. Okay, it can go into the nose and orbit, can cause nasal obstruction, epistaxis, proptosis. Okay, it can also have distant metastasis into the lung, liver, bone, spine, etc. Okay, now the important point about the nasopharyngeal carcinoma is going up into the skull base. Okay, so when it goes up into the skull base, it can involve different foramens. Generally, it tries to go into the cranial cavity through foramen lacerum or ovale. Okay, as I told you, if it goes there, it can involve multiple cranial nerves: 3rd, 4th, 5th, 6th. Okay, remember, foramen lacerum crossed, 6th cranial nerve, earliest cranial nerve to be involved, and 3rd, 4th, 5th, 6th. Remember, in the nose, we have studied the orbital apex syndrome, superior orbital fissure syndrome. So different ophthalmic symptoms such as ophthalmoplegia, proptosis, etc., they may be present in these patients. Okay, now what else can it do? It can go into the parapharyngeal space. So we have involvement of 9th, 10th, 11th, 12th cranial nerves. Now 9th, 10th, 11th cranial nerve involvement, that is known as jugular foramen syndrome. Jugular foramen syndrome is also known as Werner's syndrome. So 9th, 10th and 11th cranial nerve. So that means jugular foramen has been involved. Okay, Horner syndrome. Now Horner syndrome means that the sympathetic chain has been involved, right? So sympathetic chain is involved. So there is ptosis, meiosis, anhydrosis, and anophthalmos, right? And there is loss of the ciliary functions. So that is your Horner syndrome. Now these all may be involved when the NPC goes into the parapharyngeal space, right? Okay, where else can it go? It can also go into the retropharyngeal space. So if it goes into the retropharyngeal space, patient may have neck stiffness, pain. All right, so that was the spread of NPC. Now, let us do the staging for NPC. So we will do the T and M staging of NPC. Let us first start with the T staging for NPC. So I have kept this diagram over here. Now we know that this is the fossa of Rosenmuller. It arises from here, T1 stage. It involves the soft tissue of nasopharynx. May even go to nose and oropharynx, but only the soft tissues. Okay, so till the time it is involving only the soft tissues of nose, nasopharynx, oropharynx, it is known as stage T1. Okay, what is stage 2? It grows laterally. Where will it go laterally? It will go to the parapharyngeal space. So if it goes into the parapharyngeal space, it is stage T2. Right? Now, stage T3, it involves the bone. It involves the bone, the skull base. Now, what is there at the skull base above the nasopharynx? We have the sphenoid bone. What is there in the sphenoid bone? We have the sphenoid sinus. So, if I say that the NPC has gone into the paranasal sinus, like I have shown in this diagram over here, that means it has automatically involved the bone, it has automatically involved the skull base, it is T3. Okay, so somebody says it is in the sphenoid sinus, it is in the paranasal sinus, that means it is stage T3. Clear? All right, now stage T4. T4 means it goes up intracranial or it goes down till the hypopharynx. Okay, so that is stage T4. It goes intracranial or it goes down till the level of hypopharynx. So that is the T staging for NPC. Now let us come to the N staging. So T and M, we have done the T staging, T for tumor, tumor size, and now we come to the N. N is for lymph nodes. M is for metastasis, and we know distant metastasis, it is either M0 or M1. So M0 means no distant metastasis, M1 means distant metastasis present. We are going to discuss the N staging. M staging is common for all the malignancies across the body. We discuss the N staging. Now, N staging, let us first discuss the N staging for cervical lymph nodes. Okay, so we do the N staging for cervical lymphnopathy. Okay, we can divide the N staging into 3, N1, N2, and N3. Now, the M staging is common for all the malignancies across the body. Let us discuss the N staging. So, we will discuss the N staging first of all for all the head and neck malignancies. So, all the head and neck malignancies, they involve the cervical lymph nodes, the lymph nodes in the neck. Okay, so let us do the head and neck malignancy N staging, cervical lymph nodes lymphadenopathy staging. Now, for this, we can divide the N into 3, N1, N2, N3. Okay, and I have a very interesting way of remembering the N staging. Okay, now there is a boy, he is looking for a girl. He is looking for a girl to get married, and he has kept 3 conditions. So, what are the 3 conditions which he is looking for in the 3 qualities that he is looking for in a girl? Number 1, the first thing that he desires is that the girl is single. Of course, he wants to get married. She should not be having any boyfriend. Okay, so she is single. Right? Single. Then ipsilateral. Ipsilateral in anatomy means same side. We can say same caste, same religion, or same language. Okay, whatever, or maybe she likes her. So ipsilateral, and next is less than 3 boyfriends in the past. Okay, so single, ipsilateral, less than 3 boyfriends. Okay, so that is his criteria for finding a good wife. Okay, so our N1 is also these 3 things: single, ipsilateral, less than 3 centimeter. Okay, so N1 less than 3 centimeter, single ipsilateral, same side, right? Now, unfortunately, the boy is not able to find such a girl. Okay, so he thinks that I am not able to find N1. That means that was his best option. Single, ipsilateral, less than 3 boyfriends. Let me relax the criteria. Okay, so he goes to N2. Now, what is his N2? He will go, he says, what should I relax out of the 3? Okay, so he relaxes that, okay, so let me go from less than 3 to 3 to 6 boyfriends. So N2 is 3 to 6 boyfriends in the past. Okay, so he has relaxed one thing, 3 to 6 boyfriends in the past. So we can divide it into N2A, N2B, and N2C. So what is N2A? He is still sticking to 2 things, single, ipsilateral, but the lymph node size is 3 to 6 centimeter. So still looking for single and ipsilateral. Okay, let's say he's not able to find these 2 criteria also. Okay, so N2A is not able to find, so he further wishes to relax the criteria, so he goes to N2B. Okay, so now what is N2B? N2B is instead of single, he agrees for multiple. Okay, he thinks that she presently has a boyfriend, but if she agrees to marry with me, she will forget the boyfriend. Okay, but she should be of the same religion, and 3 to 6 boyfriends in the past, right? Okay, so N2B, multiple but still ipsilateral, and 3 to 6 centimeter. N3B is, of course, he leaves the criteria, any religion. Okay, 3 to 6 boyfriend, that is the only criteria now, 3 to 6 boyfriend. Bilateral, contralateral, okay, only criteria is now 3 to 6 centimeter. And N3 is more than 6 centimeter. Single lymph node more than 6 centimeter, that is your N3. Right? Now, remember, NPC, nasopharyngeal carcinoma, has an early lymph node metastasis, and yet the prognosis is good. Okay, the prognosis is still good. That means, what does that mean? It does not follow this staging. Okay, it does not follow this cervical lymphnopathy staging that is we have discussed for all the head and neck malignancies. So this staging is for all the head and neck malignancies except the NPC. The NPC has a special N staging. Okay, so what is the special N staging for NPC? Now we go to N1. We go to N1. N1 is simple criteria, less than 6 centimeter. You see, NPC, the nasopharynx, is in the midline. The nasopharynx is a midline structure. Now from here, any malignancy can metastasize to any side. Right side, left side, does not make a difference. Right? So any side, remember, any side, NPC, any side is not a matter over here. Any one side, right? When I say any side, it means any one side less than 6 centimeter, that is your N1, right? Now, what is N2? N2 is bilateral. N2 is bilateral, okay? Less than 6 centimeter, but bilateral. Now, N3, or rather call it as N3A, okay, and that is single node more than 6 centimeter. Single node more than 6 centimeter, that is N3A. Now we have special N staging, so we have a special N3B staging also where, okay, what is this N3B staging? Any size, any side, if the malignancy is in Ho's triangle. If the malignancy is in Ho's triangle. Now what is Ho's triangle? Ho's triangle is also known as supraclavicular fossa. This supraclavicular fossa is formed by number 1, the medial end of clavicle, B, the lateral end of clavicle, and C, where the head and see where the neck meets the shoulder. Okay, so in between these 3 points, we have a triangle known as host triangle or supraclavicular fossa, right? And this is, if the malignancy is present over here, any size, any side, it is directly N3C. Now, what is the treatment for NPC? Now, we have discussed the different TNM staging. These different TNM staging we can stage into 4 stages: stage 1, stage 2, stage 3, and stage 4. Okay, right? Of course, it becomes M1, it will come to your T stage 4. If it is T1, N0, M0, it will be stage 1. Okay, so like that we have different combinations and permutations, and we can classify into different stages. I don't want to load you up with the knowledge which will not be useful in the exam, but let's understand one thing. What treatment will you advise in the stage 1? See, in stage 1 and stage 2, early stage 2, radiotherapy is the treatment. Because this tumor is a radiosensitive tumor, okay, the NPC is a radiosensitive tumor. That is why it has a good prognosis. Remember this thing. So, in all the stages, in all stages of NPC, now mark my words very carefully, each of these words is an MCQ. All stages of NPC. If somebody asks you what is mainstay of treatment, so mainstay of treatment is radiotherapy. Okay, now in stage 1 and early stage 2, radiotherapy itself is enough. So in early stage 2 and stage 1, radiotherapy is the treatment of choice. So remember, treatment of choice word is different from mainstay of treatment. Mainstay you are giving 2 or 3 treatment, but the main treatment is radiotherapy. Okay, treatment of choice means you give a combination of treatment that together will become treatment of choice. Now stage 2 late, stage 3 and stage 4, that is the situation where the patient usually presents. Okay, stage 2 late, stage 3 and stage 4, this is the time when the patient, most of the patients will present, and in these 3 stages you will give, along with radiotherapy, you will also give chemotherapy, because radiotherapy alone is not enough. It may be mainstay of treatment, but it alone is not enough. Okay, so if somebody asks you treatment of choice, you will say radiotherapy plus chemotherapy. You can also use the word CCRT, concurrent chemo radiotherapy, or you can also use the word chemo radiation. Okay, so you can also use the word chemo radiation. Now, the next MCQ over here, suppose somebody gives you what is the treatment of choice for NPC. Okay, now this question is asked multiple times in the exam. Treatment of choice for NPC. Remember, if the word used was mainstay of treatment for NPC, answer is radiotherapy. Now, if the word used is treatment of choice for NPC and no stage is mentioned, so you see, in most cases, what we are doing? We are giving radiotherapy plus chemotherapy. So if CCRT or chemo radiation is in the option, that will be our best answer. Okay, so that will be our best answer. Like this question, it was asked multiple times. It was asked in the FMG December 2017. Treatment of nasopharyngeal carcinoma, surgery, chemotherapy, radiation, chemo radiation. So you see, radiation is there, but chemo radiation is a better answer. So you have to always choose the best answer. So answer to this question will be chemo radiation. Clear? Okay. Now, before I finish the NPC topic, we have to remember one important thing, that is the seroimmunological index in NPC. What do we mean by this? You see, the nasopharyngeal carcinoma is closely associated with Epstein-Barr virus. Okay. Now, this Epstein-Barr virus has some antigens. So, every virus has some antigens. Okay. Like in this case, we have an antigen on the capsid. That's known as viral capsid antigen. Now, against this antigen, our body produces an antibody. Now, this virus is in the nasopharynx. Now, in the mucosa, the antibody which is produced is a IgA antibody. Remember, in the mucosa, what we secrete is the IgA antibody. So, there is a IgA antibody produced for the viral capsid antigen, VCA. Okay. Now, this VCA, IgA to VCA, if you detect this, it has 97% specificity and 95% sensitivity to detect the NPC. Okay, to detect the NPC. The second antigen that is released by the Epstein-Barr virus is the early antigen. So again, we have an antibody to it that is known as IgA to EA. This has 99% specificity and 90% sensitivity. Now, where do we use these two antibody titers? Where do we use IgA to VCA and IgA to EA? They can be used in two ways. Which two ways? Number one, we can use them to follow up a patient for recurrence. Suppose there is a patient who had NPC, has been treated by NPC. Now, the prognosis for NPC is good. So, a lot of patients will live out the NPC. So, you have to follow them up. So, the best way to follow them up, whether the NPC is growing again, is to do the antibody titers for IgA to VCA and IgA to EA. Right? So, these two can be used. Suppose these titers start increasing, that means there is a recurrence of NPC. Other than that, we can also use it. See, these are seroimmunological index. So, they can also be used for screening in high-risk populations. Okay. So, they can be used in screening in high-risk population. Now, so as I said, we can use the prognostic markers IgA to VCA and IgA to EA. Now, let's say we have to use them for screening in a high-risk population. Now, which one you will use? Now, remember, for screening, for the purpose of screening, what is more important for us? Specificity or sensitivity? What is more important for us is sensitivity. Screening means we want to detect as many as possible. So, that means sensitivity is more important to us. Okay, right? We should not miss out any patient. So, this IgA to VCA is having a very high sensitivity. Therefore, this is used for serological screening of NPC. In high-risk patients, we use IgA to VCA, and this question has been asked in the exam multiple times. Right? So, that was about the NPC and the nasopharynx in total.